Hey guys, welcome to another episode of the Human AI podcast. Today we're going to talk about resistance, we're going to talk about obstruction and ventilation, and I'm here with Grok, an AI. It's going to be explaining to us today's topics. I hope you find the video enjoyable and informative. However, I do want you guys to cross-reference things you hear and take things with a pinch of salt since they're coming from AI, basically. I still hope you find them valuable though, because a lot of the things are accurate. Okay, let's start with today's topic, Grok. Make us an introduction on today's topic, and we'll go from there.
All right, today we're diving into resistance and obstruction in ventilation, which is all about how air moves through the lungs and what can make breathing harder. We'll explore what causes airway resistance, how obstructions like asthma or COPD mess with airflow, and why these issues matter for lung function. Ready to jump in with any specific angle or question?
Yes, sir.
Cool. Let's get rolling. So, airway resistance is basically the force that opposes airflow in the respiratory tract, and obstructions like asthma or COPD crank that resistance up, making it tough to breathe. Want to start with what causes airway resistance, or zoom in on a specific condition like asthma?
Before we do that though, I want to also focus on when we experience this resistance and obstruction, and I'm reverse engineering here, guys. What do we need to do? Do we need to wear a face mask, maybe some kind of oxygen delivery device, administer oxygen?
When dealing with resistance and obstruction in ventilation, like in conditions such as asthma or COPD, the approach depends on the severity and cause. Face masks or oxygen delivery devices, like nasal cannulas or non-invasive ventilation masks, are often used in severe cases to deliver supplemental oxygen or assist breathing when airflow is significantly restricted, especially in acute exacerbations or chronic conditions with low oxygen levels. However, they're not the first step medications, like bronchodilators, e.g., albuterol, to open airways, or corticosteroids to reduce inflammation are typically the go-to for managing obstruction, alongside
So you're saying bronchodilators and corticosteroids are first line.
Yeah, exactly. Bronchodilators, like albuterol, relax the airway muscles to quickly open up the passages, making them the first line for immediate relief in conditions like asthma or COPD. Corticosteroids, like inhaled budesonide, reduce inflammation over time and are often used alongside bronchodilators for long-term control, especially when obstruction is persistent or severe.
Very interesting. Okay, let's focus a bit on the masks, and then we'll talk a bit about the drugs, and then we will obviously talk a bit more about what resistance and obstruction means. So with a simple face mask, we wear it in our face, we get some oxygen. It's got a hose in the side, we can exhale, some air can be exhaled, then it can escape. Well, what about other devices? For instance, we have nasal cannula, we have venturi valves, we have non-rebreather mask. Tell me about the pros and cons, the differences.
All right, let's break down oxygen delivery devices, focusing on nasal cannula, venturi mask, and non-rebreather masks, since you mentioned simple face masks already. Nasal cannula. This is a lightweight setup with two prongs that sit in your nostrils, delivering low-flow oxygen, typically 1.6 liters per minute, which gives about 24 to 44% oxygen concentration. Pros are, it's comfortable, allows eating and talking, and is great for stable patients needing mild support, like in early COPD. Cons are, it's less effective for severe hypoxia, since it delivers lower oxygen concentrations, and it can dry out nasal passages. Venturi mask. This uses a valve system to deliver precise oxygen concentrations, ranging from 24 to 60%, by mixing oxygen with room air at specific ratios. Pros include accurate oxygen delivery, ideal for patients needing controlled doses, like in COPD, where too much oxygen can suppress breathing. Cons are, it's bulkier, can feel restrictive, and requires correct valve setup to work properly. Non-rebreather mask. This covers the nose and mouth with a bag reservoir, delivering high-flow oxygen up to 90-100% at 10-15 liters per minute, with one-way valves to prevent exhaling carbon dioxide back into the bag. Pros are, it's great for emergencies with severe hypoxia, like acute asthma attacks. Cons include discomfort, difficulty talking or eating, and risk of oxygen toxicity if used too long. Each device matches different needs. Cannula for mild cases, Venturi for precise control, and non-rebreather for critical situations. Want to dive deeper into one of these or move to the drugs?
Well, this is good. In a sentence or two, though, I want to understand like why don't we use the best mask for everyone? Like the most efficient, like the most oxygen delivery one, the non-rebreather one.
Non-rebreather masks deliver near 100% oxygen, but aren't used for everyone because high oxygen levels can suppress breathing in some patients, like those with COPD, and they're less comfortable for long-term use compared to simpler devices like nasal cannulas. The choice depends on the patient's oxygen needs, comfort, and risk of complications like oxygen toxicity.
Interesting. Okay, tell me a bit about how oxygen administration changes alveolar oxygen. Why does it increase fractional inspired oxygen? And yeah,
Oxygen administration boosts alveolar oxygen by increasing the fractional inspired oxygen, or FiO2, which is the percentage of oxygen in the air you breathe in. Normally, room air has an FiO2 of about 21%, but devices like nasal cannulas, Venturi masks, or non-rebreathers can raise this to 24 to 100%, depending on the device, delivering more oxygen to the alveoli in the lungs, where gas exchange happens, so more oxygen gets into the blood.
can you explain this one more time, please? And perhaps also explain to me Henry's law and how oxygen is driven by partial pressure gradient from alveolus to the blood.
All right, let's clarify how oxygen administration affects alveolar oxygen and tie in Henry's law. When you use devices like nasal cannulas or non-rebreather masks, they increase the fractional inspired oxygen, FiO2, which is the proportion of oxygen in the air you inhale, normally 21% in room air, but up to 100% with something like a non-rebreather. This higher FiO2 means more oxygen reaches the alveoli, the tiny air sacs in the lungs, boosting the partial pressure of oxygen there, which drives more oxygen into the blood during gas exchange. Now, Henry's law comes into play. It states that the amount of gas, like oxygen, dissolved in a liquid, like blood, is proportional to the partial pressure of that gas above the liquid. In the alveoli, the higher partial pressure of oxygen, thanks to increased FiO2, pushes more oxygen molecules to dissolve into the blood plasma and bind to hemoglobin.
Can you summarize everything in 3 sentences?
Oxygen administration devices like nasal cannulas, Venturi masks, and non-rebreathers increase the fractional inspired oxygen, FiO2, raising alveolar oxygen levels to enhance oxygen transfer into the blood. Per Henry's law, the higher partial pressure of oxygen in the alveoli drives more oxygen to dissolve into the blood, following the pressure gradient. These devices are chosen based on patient needs, with non-rebreathers for emergencies and cannulas or Venturi masks for stable or controlled oxygen delivery.
So
While
how
bron-
does exhalation occur with a non-rebreather mask on? So it's got 2 sets of one-way valves, and yeah, these can occasionally fail.
With a non-rebreather mask, exhalation happens through one-way valves on the sides of the mask, which open to let exhaled air, mostly carbon dioxide, escape into the atmosphere while preventing room air from entering. The mask's reservoir bag, filled with oxygen, has a one-way valve to ensure you inhale nearly 100% oxygen, but if these valves fail, Due to damage or improper fit, exhaled carbon dioxide can get trapped, reducing oxygen delivery and potentially causing rebreathing issues.
Okay.
Want to dive into valve?
Interesting. Let's talk a bit about how high altitude can affect fractional inspired oxygen, partial alveolar, and arterial oxygen.
At high altitude, the fractional inspired oxygen, FiO2, stays the same, about 21% in atmospheric air, since the proportion of oxygen doesn't change. However, because air pressure drops with altitude, the partial pressure of oxygen in the alveoli, PaO2, decreases, leading to less oxygen available for diffusion into the blood, which lowers arterial oxygen pressure, PaO2, and can cause symptoms like shortness of breath or hypoxia. This happens because the lower atmospheric pressure reduces the driving force for oxygen to move from the alveoli to the bloodstream.
I don't get it, dude. Can you explain it a bit more simply? Couple of sentences.
At high altitude, the air is thinner, so even though the oxygen percentage stays 21%, there's less pressure pushing oxygen into your lungs and blood. This lowers the oxygen in your alveoli and arteries, making it harder to breathe and potentially causing dizziness or fatigue.
Okay. And what about airway resistance? Explain us airway resistance. Well, explain us about the friction between gas molecules. Yeah.
Airway resistance is the opposition to airflow in the respiratory tract, caused by friction between gas molecules and the airway walls, especially in narrower passages like the bronchi. It's influenced by airway diameter. Smaller airways, like in asthma or COPD, increase resistance, making breathing harder. Think of blowing through a straw versus a pipe. Friction also comes from turbulent airflow, especially in constricted or mucus-filled airways, requiring more effort to move air in and out. Want to dig into what causes changes in airway diameter or how this ties to obstruction?
I want to ask you about airway radius and laminar flow. So, explain to me how resistance is inversely proportional to the radius and flow too.
All right, airway resistance is heavily tied to airway radius, and it follows Pizaiway's law, which says resistance is inversely proportional to the radius to the fourth power. In simple terms, if the airway radius halves, resistance skyrockets 16 times, making it much harder for air to flow. Laminar flow, where air moves smoothly in layers, happens in wider airways and keeps resistance low. But when airways narrow, like in asthma or bronchitis, flow becomes turbulent, increasing friction and resistance even more. Want me to break down how this impacts breathing effort or specific conditions?
That's good. Okay, let's talk about what impedance is too, how it affects air resistance and tissue stiffness. And why doesn't high airway pressure mean high alveolar pressure initially?
Impedance in the lungs refers to the total opposition to airflow and lung expansion, combining airway resistance, friction from air moving through airways, and tissue stiffness, the resistance of lung and chest wall tissues to stretching. High airway pressure, like during mechanical ventilation, doesn't instantly mean high alveolar pressure because the pressure must overcome airway resistance and the elastic recoil of tissues first, causing a delay as air navigates narrow or obstructed airways and stretches the alveoli. This is why conditions like asthma with high resistance or fibrosis with stiff tissues increase impedance, making it harder to inflate the lungs fully. Want to dive into how this affects ventilation strategies or specific diseases?
This is good. So what's the small airways trumpet thing?
The small airways trumpet refers to how the total cross-sectional area of the smaller airways, like bronchioles, increases dramatically as they branch out, resembling the flared end of a trumpet. This reduces airway resistance in these tiny passages because despite each bronchiole being narrow, their combined area lowers the friction for airflow, per Pizaiway's law. making it easier for air to reach the
So
alveoli.
individually, each airway at the bottom in the narrow bit has a higher resistance than any larger airway. However, in total, in parallel, all the small ones have a low resistance. Or did I get it wrong?
You've got it right. Each small airway, like a bronchiole, has higher resistance individually because of its narrow diameter, as per Pazaiway's law, where resistance shoots up when radius shrinks. But because there are so many bronchioles in parallel, their combined cross-sectional area is huge, which lowers the total
And
resistance
is
to
this
airflow.
at the end of the trumpet, at the large diameter bit of the trumpet, or at the narrow diameter bit of the trumpet?
The small airways trumpet analogy refers to the small airways, like the bronchioles, which are at the narrow end of the trumpet in terms of individual diameter. Their large total cross-sectional area, due to their vast number in parallel, mimics the flared, wide part of a trumpet, reducing overall resistance to airflow. Want to connect this to a specific condition or dive deeper?
Wait, I'm confused. So what you're saying is, I don't get it, dude.
All right, no worries. Let's simplify the trumpet thing. Picture the airways like a trumpet. Each small airway, like a bronchiole, is super narrow, so on its own, it has high resistance to air.
I get that, but I don't get the trumpet analogy. What does it have to do with trumpet?
Okay, let's clear up the trumpet analogy. The small airways trumpet describes how the tiny bronchioles, though individually narrow, like the mouthpiece of a trumpet, branch out so much that their total combined area is massive, like the wide, flared bell
I
of a.
see. Okay, and let's talk a bit about fixed obstruction now. What's fixed obstruction?
A fixed obstruction is a blockage in the airway that doesn't change with breathing, like a tumor, scar tissue, or foreign object stuck in the trachea or main bronchi, causing constant resistance to airflow. Unlike dynamic obstructions, like asthma, where airways narrow variably, fixed obstructions stay put, reducing airflow consistently and often requiring interventions like surgery or stents to clear the blockage. Want to dive into specific causes or treatments for fixed obstructions?
No, this is great for now. And what is variable resistance? So some small airways or alveoli, they collapse. We have this prevention of gas behind leaving. How does this relate with variable resistance?
Variable resistance, often called dynamic obstruction, happens when airways, especially small ones, like bronchioles, narrow or collapse during breathing, typically during exhalation, due to factors like airway smooth muscle constriction or loss of elastic support, as seen in conditions like asthma or COPD. When small airways or alveoli collapse, it traps gas behind the obstruction, preventing proper exhalation, which increases resistance variably because the narrowing worsens with breathing efforts or triggers like allergens. This differs from fixed obstructions, as the resistance fluctuates with breathing phases or stimuli, making exhalation harder and leading to air trapping or hyperinflation. Want to explore how this impacts lung function or specific treatments?
I want to ask you about reading airflow versus volume graphs, especially when we have problems such as obstruction and restriction.
All right, let's talk about reading airflow versus volume graphs, specifically flow volume loops for obstruction and restriction. In a flow volume loop, the x-axis shows lung volume, from total lung capacity to residual volume, and the y-axis shows airflow rate, positive for exhalation, negative for inhalation. For obstructive disorders like asthma or COPD, the loop shows a scooped-out exhalation curve because airway resistance increases, especially in small airways, reducing peak expirative flow and making it harder to push air out, so the curve dips inward. In restrictive disorders, like pulmonary fibrosis, the loop is narrow and tall since lung volume is reduced due to stiff tissues, but airflow rates remain relatively normal, giving a smaller total volume but a steep, near-normal shape. Want me to break down specific patterns or how to spot severity in these graphs?
I want to ask you about extrathoracic versus intrathoracic variable resistance, and tell me in a couple of sentences.
Extrathoracic variable resistance occurs in the upper airway, e.g., larynx or trachea, outside the chest, where obstructions like vocal cord paralysis worsen during inhalation due to negative pressure collapsing the airway. Intrathoracic variable resistance happens inside the chest, e.g., lower trachea or bronchi, where obstructions like tumors or COPD worsen during exhalation due to positive pressure compressing the airways.
And what is resistance of multiple airways?
The resistance of multiple airways, when arranged in parallel, like the bronchioles in the lungs, is lower than the resistance of any single airway because the total resistance is calculated as the inverse of the sum of the inverses of individual resistances. 1 R total plus 1 R1 plus 1 R2 plus some constant. This means the more airways you have in parallel, the easier it is for air to flow, which is why the small airways combined large cross-sectional area, like in the trumpet analogy, reduces overall resistance despite each airway being narrow. Want to dive into how this applies to specific lung conditions?
Can you explain to me why, if I have a graph of air volume and positive pressure, with air volume and positive pressure being on the y-axis and x-axis respectively, the exhalation will be closer to the y-axis than the inhalation?
When you plot air volume on the y-axis and positive pressure on the x-axis, you're likely looking at a pressure-volume curve for the lungs. During exhalation, the curve is closer to the y-axis than during inhalation because exhalation requires less pressure to move air out, especially early on, due to the elastic recoil of the lungs naturally pushing air out. Inhalation, on the other hand, requires more positive pressure to overcome lung and chest wall resistance and expand the alveoli, so its curve shifts further from the y-axis, creating a wider loop in the pressure-volume graph.
That makes sense. Okay, now let's talk about BPAP and type 2 respiratory failure in a couple sentences, please.
BPAP, or bilevel positive airway pressure, delivers higher pressure during inhalation and lower pressure during exhalation to support breathing in type 2 respiratory failure, where high carbon dioxide levels result from inadequate ventilation, often seen in conditions like COPD. It helps open airways, improve gas exchange, and reduce the work of breathing without needing invasive ventilation. Want to dive deeper into BPAP settings or type 2 failure causes?
I want to ask you about stenting with positive airway pressure. What is positive end expiratory pressure? TEEP.
Positive end expiratory pressure, or PEEP, is a setting used in mechanical ventilation or devices like BiPAP, where a small amount of positive pressure is maintained in the airways at the end of exhalation to keep the alveoli open. This prevents collapse of small airways, improves oxygen exchange, and reduces the work of breathing, often used alongside stenting in severe cases like airway obstruction to maintain airway patency and enhance ventilation. Want to explore how PEEP interacts with stents or its specific benefits in conditions like COPD?
I want to ask you about obstructive sleep apnea.
Obstructive sleep apnea, OSA, is a condition where the upper airway repeatedly collapses during sleep, causing pauses in breathing, apnea, or reduced airflow, hypopnea, leading to drops in blood oxygen and disrupted sleep. It's often linked to factors like excess weight, narrow airways, or relaxed throat muscles, and is treated with CPAP, continuous positive airway pressure to keep airways open, lifestyle changes, or sometimes surgery. Want to dive into symptoms, treatments, or how it relates to airway resistance?
That's so good. And what are some clinical symptoms?
Obstructive sleep apnea commonly causes loud snoring, gasping or choking during sleep, daytime fatigue, morning headaches, and difficulty concentrating due to disrupted sleep and low oxygen levels. Other symptoms include irritability, dry mouth upon waking, and frequent nighttime urination, often worsening if untreated and leading to risks like hypertension or heart issues. Want to explore diagnostic tests or specific treatments for these symptoms?
Well, I would like to understand obstructive sleep apnea's pathophysiology and treatment. So nasal CPAP and non-CPAP treatment. Yeah.
All right. Let's break down the pathophysiology and treatment of obstructive sleep apnea, OSA. OSA. OSA happens when the upper airway, like the throat or tongue area, collapses or narrows during sleep due to relaxed muscles, excess tissue, or anatomical factors like a small jaw. This blockage increases airway resistance, causing breathing pauses, apnea, or reduced airflow, hypopnea, which drops blood oxygen levels and spikes carbon dioxide, triggering brief awakenings to restore breathing and disrupting sleep. Over time, this stresses the heart and raises risks for hypertension and cardiovascular issues. For treatment, nasal CPAP, continuous positive airway pressure, is the gold standard. It delivers steady air pressure through a mask to keep the airway open, preventing collapse during sleep. It's effective, but can be uncomfortable, so compliance is a challenge. Non-CPAP treatments include lifestyle changes like weight loss to reduce airway obstructing tissue, avoiding alcohol or sedatives that relax throat muscles, and sleeping on your side to prevent tongue collapse. Oral appliances that reposition the jaw or tongue work for mild cases. Surgery, like uvulopalato-pharyngopoly or UPPP or tonsillectomy, can remove or reshape tissue in severe cases, and in rare instances, tracheostomy bypasses the upper airway entirely.
Okay, let's talk just a few sentences on the surface tension of the alveolus and why it's necessary, and how surfactant reduces surface tension. Also, if you could tell me in a sentence again about what does type 1 and type 2 respiratory thing means, and tell me about type 2 alveolar cells and how they are related to the surface tension. Tell me about DPPC too. I know it's a lot of things. We're running out of time and I want to keep this 30 minutes. Just summarize everything I've asked in perhaps 4 sentences.
Surface tension in the alveoli arises from water molecules creating a cohesive force that makes alveoli prone to collapse. But surfactant, produced by type 2 alveolar cells, reduces this tension to keep alveoli open for easier breathing. Surfactant contains dipalmitoyl phosphatidylcholine, DPPC, a phospholipid that lowers surface tension by disrupting water molecule cohesion, stabilizing alveoli, especially during exhalation. Type 1 respiratory failure is low blood oxygen, hypoxemia, without high carbon dioxide, while type 2 involves both low oxygen and high carbon dioxide, hypercapnia, due to poor ventilation, often seen in obstructive conditions like COPD. Type 2 alveolar cells secrete surfactant, which is critical for reducing surface tension, preventing alveolar collapse, and aiding efficient gas exchange in the lungs.
And what is neonatal respiratory distress syndrome? And tell us that in a sentence. And in one more sentence, tell us again about type 1 and type 2. And also one more sentence on how surfactant reduces surface tension, although we kind of covered that.
Neonatal respiratory distress syndrome, NRDS, occurs in premature infants when insufficient surfactant produced by type 2 alveolar cells leads to high alveolar surface tension, causing alveoli to collapse and making breathing difficult. Type 1 respiratory failure is low blood oxygen, hypoxemia alone, while type 2 is low oxygen with high carbon dioxide, hypercapnia, due to impaired ventilation. Surfactant rich in DPPC reduces surface tension, preventing alveolar collapse and aiding efficient gas exchange. Reduces alveolar surface tension by disrupting water molecule cohesion, stabilizing alveoli for easier lung expansion.
Okay, perfect. Well, Guys, this was it for this episode. Thank you so much for watching, and I'll see you next time. Peace.